I'm delighted to introduce our next speaker, Dr. Bryna Koch, whose expertise in rural health will provide valuable insights into our next presentation titled Addressing Rural Arizona's MCH Health Workforce Needs, Issues, and Solutions. Dr. Bryna Koch is an assistant research professor at the University of Arizona, Zuckerman College of Public Health. Since 2016, she has worked at the Arizona Center for Rural Health, where she supports programs and projects by providing data collection, management, analysis, and reporting expertise. Currently, her primary focus is on health workforce data collection, synthesis, and reporting in order to inform public health and healthcare partners about statewide workforce needs. She is also interested in how the field of public health can effectively communicate information and data to inform policy and public health approaches. Dr. Koch has over 15 years of public health and education evaluation experience and has collaborated with community based programs, non for profit organizations, and governmental agencies. I now turn the floor to Dr. Koch.
Today, I'm going to talk to you about some of the rural health workforce needs that are related to maternal health in Arizona and talk about some of the existing policy solutions and policies that I think are particularly important or relevant to rural maternal health in Arizona. So again, my name is Bryna Koch. I'm an assistant research professor at the Arizona Center for Rural Health, Zuckerman College of Public Health. My employer is the University of Arizona, and I have no other financial or non-financial disclosures to present to you today. So first, a little bit of background on the Center for Rural Health. Our mission is to improve the health and wellness of Arizona's rural and underserved populations. And the guiding principles that we use for this work are really recognizing the uniqueness of rural communities. And I want to put a plug in here, and this really includes the diversity of rural communities that are included within Arizona. Right? We have linguistic, social, racial, and ethnic, and historical diversity amongst our rural communities across the state. And so I really want to emphasize that, and it's really important to our work that our rural communities are not homogenous in the state. We really focus on principles of the healthcare system in rural areas, really focused on ensuring access to care and that the level of care is of the same quality between rural and metro areas in Arizona. We also want to really focus on using our resources at the university and at the Center for Rural Health to serve as a voice for Arizona's rural populations, right? Then that really speaks to the first keynote presentation today about educating policymakers and others about the needs in rural Arizona. So I particularly at the center focus on health workforce data collection and analysis. And what that work, the intent of that work really is to inform our partners throughout the state as they are writing grants, designing programs, and developing policies, right? So getting them the data that they need to make the most informed choices when it comes to those programs, policies, and projects. Within the center and within our workforce efforts, we collaborate with other statewide partners, including the Department of Health Services, and kind of uniquely in terms of supporting the health workforce, we have a partnership with the Department of Health Services and the Arizona Alliance for Community Health Centers, where between our three organizations, we support a program called 3RNet, which is specifically a rural recruitment program for health professionals. And there are 3RNet programs across the United States, but ours in Arizona is unique because it is this kind of three-part partnership between the Department of Health Services, AACHC, and the Arizona Center for Rural Health. So that's just kind of an overview of some of the workforce efforts that go on at the Center for Rural Health. So what I want to talk to you about a little bit is the healthcare context in rural Arizona. So one, there are rural communities in every county in Arizona. Even in Maricopa and Pima County, there are rural communities, right? We have 15 really large geographically and socially diverse counties. And within those counties, there are metro, less metro, and more rural areas. These rural areas are usually typified by low population numbers, low population density, really large physical, geographic spaces, which contributes to a longer travel time and distance to metro areas. And why that's important in the context of healthcare access, right, is that healthcare resources tend to be clustered in metro areas, right? And they're kind of over clustered in metro areas, right? So you see more resources available to folks in those metro urban areas than are available to folks in rural areas. And so, we really see this when we look at ratios of healthcare professionals, the healthcare workforce, right? In rural Arizona, there are fewer total healthcare professionals across, many of the healthcare professional types that we look at in our data analysis. And there are lower ratios of providers per population, right? So it's not just like, well, there's fewer providers because there's fewer people, but actually the ratio is lower in rural Arizona of providers to population for most sets of providers that we look at. And really what this kind of impacts for folks in rural areas is their ability to access care when they need it, right? And the continuity of care that they might need in terms of, dealing with more complicated or kind of the perinatal period, right, of conditions where that might require, pre and post care and a continuity of care across different provider types. So we want to talk a little bit about geographic proximity. And so, the data in terms of healthcare access does pretty clearly show that when your source of care is farther away from you, you are less likely to receive that care. And we see this particularly for primary and preventive care, right? Further away it is, the less likely you are to receive it. And of course, for people who live in rural areas that might be very distant from healthcare systems or facilities or health clinics or centers, right? This geographic proximity can really impact their ability to access care. Also, I want to emphasize that, right, it's not just kind of this geographic distance that someone might have to overcome, right? We want to think about the intersection of different challenges, right? So not just the distance, right, but also how it affects people who have less economic resources, who have lower literacy or health literacy, who are older, or who come from under-resourced communities, right? And how all those factors might combine to really limit someone's ability to access care in a timely fashion. And when we think about overcoming these geographic distances, there's some costs, there's some real costs to overcoming those barriers, right? Think about the economic costs, right? So overcoming these distances, given kind of transportation infrastructure, particularly in rural areas, it requires having a personal vehicle, right? So you have the cost of the personal vehicle, you have the maintenance of that vehicle, you have the gas costs, right, to drive. If you're driving, an hour each way for an appointment, that's potentially 3 hours of your day, right? Do you have the work structure? Do you have a job that provides you the benefits and the flexibility to be able to take 3 hours out of your day to access healthcare and to seek a healthcare appointment? There's also potential social costs, right? And this has come up a little bit in the perinatal health literature, right? As when someone has to seek care, distant from their social safety net, their community, and they may have to stay there for more extended periods, right? Then you might be removing someone who needs social support from their kind of existing community and other social support that they have. So there's some real costs to being, not nearby and not able to access care in a geographically proximal way. The Department of Health and Human Services has a travel standard, a distance standard, where and this is a standard they use to designate their health professional shortage areas. And it's anything over 30 minutes is considered excessively distant in terms of access to care. So I just want to contrast this with what is in the state Medicaid program network adequacy standards for obstetric and gynecologist access in Arizona, right? So in all counties outside of Maricopa and Pima County, the network access standard for the health insurers who participate in access for access to obstetric and gynecology specialty care is that 90% of members in any county outside Maricopa and Pima do not need to travel any more than 90 minutes or 75 miles. So that's the upper threshold. So the upper threshold could be up to 89 minutes for someone to access obstetric gynecology care in Arizona. And that's the network standard. That's 3 times what DHHS says is excessively distant. So we are, and if we're traveling, 89 minutes, that's 3 hours of just travel time. That does not include appointment time, right? Or any potential delays. So I think that just kind of emphasizes the distances, right, that people in rural areas have to go to access care. So I emphasize, the geography and rural geography a lot, just to say, just as the prior presentation encouraged folks to, consider incarceration as an aspect when we're talking about perinatal and maternal health, to also consider geography as we're talking about health disparities and, remediating those health disparities by using a health equity framework. And even though I focused a lot on geography because that's where I'm coming from, the Arizona Center for Rural Health, I do also want to emphasize that just having geographically proximal care doesn't ensure access, right? So we know that even in metro areas where there is greater availability of healthcare resources, that doesn't always ensure access, right? So that's really important about kind of thinking about all those factors together and bringing that health equity and kind of intersectional lens to understanding access. So the healthcare conditions in rural Arizona that are really influencing maternal health and perinatal health include kind of general rural healthcare conditions, right? So there is, less access to preventive and primary care, longer distances to healthcare. At the community and environmental level, we see higher rates of uninsurance in rural Arizona and higher rates of Medicaid coverage among rural populations. Specific to perinatal healthcare conditions, this mirrors the general healthcare conditions, right? We see fewer obstetric providers, less access to perinatal care, and limited nearby or proximal access to hospitals with those higher level acuity of services. And in thinking about, rural urban maternal health disparities, one of the underlying factors, right, that is hypothesized to be driving some of those disparities is this kind of lack of access to care and the necessary providers to support maternal health. So I want to focus on and frame the information I'm going to present today on a recent report in a series, but this is the most recent report on maternal mortality from the Maternal Mortality Review Committee in Arizona. This report came out, I believe, in February of 2024 and reviewed data from 2018 to 2019. And similar to the prior report, this report did find that there is a disparity between birthing people from rural areas compared to urban areas in their rate of maternal mortality. And this is a trend that is also mirrored at the national level. And what I also want to present today is a little bit of information on the behavioral health workforce. And really, I chose that for inclusion because when I was reading this most recent report from the Maternal Mortality Review Committee, really what they were looking at is, they identified some of the underlying and contributing factors, to these deaths. And they identified that substance use and mental health disorders were some of the leading contributing factors to maternal mortality in Arizona. And they did not specifically kind of divide this area by rural urban. This is just for all the maternal mortality data that they reviewed. So when we're looking at maternal healthcare professionals in urban and rural Arizona, you all may be familiar with this map. This is my recreation of the March of Dimes maternity care desert map. So they identify that there are 2 counties that have no maternal care providers or facilities, 2 counties that have very low access to maternity care, and then counties that have full access to maternity care. Now, what I want to emphasize from this map is that this is at the county level. Our counties in Arizona, as you probably all know, are bigger than some states, right? So within each of these counties, so this is just kind of a snapshot. And what I want to emphasize is that within each of these counties, there's really varying degrees of access to the healthcare resources in these counties. But this is the kind of broad county level scope of some of the real areas of needs in terms of workforce and facilities in Arizona. When we looked at obstetric gynecologist physician providers in Arizona using Arizona licensure data from the medical and the osteopathic boards, we found, like, as you know, you may not be surprised from the prior slides, that there is a really significant clustering of obstetric gynecologist physicians in urban areas in Arizona. And you see a really kind of significant decrease in the availability of those providers in large rural, small rural, and none in isolated rural Arizona. When we looked at nurse midwives, so these are the APRN CNMs, what we found was a slightly a different pattern and then a shared pattern, right? So we found that in terms of nurse midwives, the clustering was not as severe, right, in urban areas. There was actually more of a sense of parity in the availability of nurse midwives in urban compared to rural Arizona. But again, we found that there were no nurse midwives in those places of isolated rural Arizona. We also have analyzed behavioral health care professional data. And just at a very broad level, using the Department of Health and Human Services health professional shortage area data, they find that Arizona currently, just broadly across all populations, is only meeting 9% of our mental health needs. Now, this calculates health professional shortages for mental health using psychiatrist physicians only. So I just want to clarify, this is focused just on that subset of behavioral health professionals. The Department of Health and Human Services estimates that we need as many as 228 psychiatrist physicians right now just to meet our current needs in Arizona. And just to emphasize the threshold that we're looking at for health professional shortage areas, the designation threshold is a population to provider ratio of 30,000 to 1 or 20,000 to 1 in high needs areas. When we group the need by county, you know, we see that there are, people in all counties living in mental health or behavioral health professional shortage areas. And the FTE needs are spread across the state, across all 15 counties. When we specifically look at that kind of sub-county level definition of rurality, and we look at psychiatrist physicians, again, using Arizona health licensure data, again, we find that real clustering of psychiatric physicians in urban areas in Arizona, and a really significant decrease, right, between urban and large and small rural areas. And when we looked at other behavioral health professionals using data from their licensing boards, we also found a similar pattern of this disparity for social workers, counselors, psychologists, and marriage and family therapists, right? So this pattern of metro clustering and really decreasing availability in rural areas holds true for these professionals as well. However, there's one subgroup of the workforce that of the behavioral health workforce that didn't show this pattern, so I want to highlight it here. And this is shows that there is more parity between rural and urban Arizona for substance abuse counselors in the state. I just want to flag some limitations of this data for awareness, and I'm happy to answer questions about the data, and I'll have my email on the slides, and if you have questions, we can talk more. But the data that we use for this type of analysis is licensure data from the health professional licensing boards. It doesn't reflect, it only reflects if someone's maintaining an active license, right? It does not reflect if they're actually in the clinical workforce. So it's a really important question and limitation of this data. It doesn't address any possible kind of address or location issues, right? We use an address to map where we think this person is in the state, right? But if that address is inaccurate, there could be some inaccuracies there in our geographic analysis. And for physicians in the licensing process report their areas of interest. This does not reflect board certification, right? So, we make an assumption that if someone says, yes, I'm a practicing obstetric gynecologist, that they are also we hope that they are board certified in that area, but we cannot say that from the data. Right? We don't know what this data doesn't tell us, who's being accepted for care by these providers, right? Do they accept Medicaid? Do they accept any health insurance, right? Or, maybe for the behavioral health providers, they've gone totally to self-pay, right? So we know that that's also a barrier that would not be addressed by this data. But using these limitations to talk about something that we can all do to address these limitations, there is a process developing by the Arizona Department of Health Services and other stakeholders across the state to integrate a survey at the time of licensure to collect more of this data from health professionals as they get licensed to help us fill in the gaps about what we don't know about our health workforce in Arizona. So I just want to put in a plug for that survey for any of those of you who are licensed health professionals and renew your licensure every 2 or 4 years. Please take the time to fill out those 15 questions because it will encourage your collaborators and colleagues to do so, because it will really provide really critical information about the health workforce in Arizona. So now getting to the questions of what are we doing about some of these workforce needs and gaps. So the first thing I want to highlight before we get into the policies that are addressing some of these gaps is that there are, we've been talking about a disparity, but I don't want that disparity to become the overriding lens of how we think about rural Arizona. So I want to highlight that there are strengths of any community, there are strengths of rural communities that can be built on in terms of any type of intervention or program or policy, right? And so I just wanted to take the moment to highlight some of these strengths here. So there are many initiatives, many policies unfolding across the state. There's no way I'm going to include everything, and I apologize in advance for that. And if it does seem like I have a little bit of a University of Arizona centric lens, I do, and I apologize, but please, put programs and initiatives in the chat that you might be aware of. But I'm just going to highlight a few here. So across the 3 state schools, right, there is the Healthy Tomorrow Initiative, right, which is an expansion of medical nursing and other programs. Specifically at the University of Arizona, we are expanding our physician assistant. They're really important for the maternal perinatal health issues and nurse midwife program expansion, and physician and physical therapy programs, right? So these are also types of providers where you see less of you see less of a disparity between urban and rural location, right, than you might see amongst physician providers. There are also programs, right, that support future health professionals to practice in rural and underserved areas, right? So there are scholarship programs at the University of Arizona, right, that provide scholarships to folks who after their residency commit to practicing in a rural or underserved area in primary care. And we talk about how primary care is one of those critical needs in rural Arizona. There is, of course, the suite of state workforce loan repayment programs that are managed by ADHS. And what I want to highlight here for these loan repayment programs is that just within the last couple of years, behavioral health professions have come on board as eligible for loan repayment, right? So that's kind of, critical to being able to encourage health professionals to work in rural areas, and then have that benefit of loan repayment come out of that commitment. There are federally qualified health centers in Arizona who are running teaching health center programs, right? The idea is getting physician residents that community-based exposure in rural areas will increase the likelihood that they remain to practice, right, after their residency programs in those rural or underserved areas. At the University of Arizona, and we house the Arizona Area Health Education Center, but this program actually supports programs across state and other universities that support clinical rotations for students in many different health professions. Again, the idea is that getting students in the training and in the residency programs, experiencing communities in rural Arizona will increase the likelihood that they practice in these areas. There is a new developing rural residency program. It also run out of the Arizona Area Health Education Center. I think there's some really critical professions being included in this program when we're talking about the potential impact on maternal perinatal health, particularly family medicine and psychiatry professionals. There's a great program from the Arizona Hospital and Healthcare Association, again, really focused on getting behavioral health professionals out into our rural healthcare facilities, like critical access hospitals, Indian health service facilities, and other facilities that serve rural Arizona. When you can't get professionals into an area, you can connect professionals that are in those rural areas with other workforce professionals in the state, right? And these are 3 programs that really use technology to connect professionals so that they can learn from each other and share, best practices and high quality care. So the Arizona Telemedicine Program, Project Echo, and the Arizona Perinatal Psychiatric Access Line. So just to wrap up, I'm going to talk a little bit about what else we can do and what else maybe we should do and investigate as policy options. And these are all things that really address some of the key recommendations from that maternal mortality review committee report, right? That focus on, bolstering continuity of care and care coordination, increasing access to high quality mental and behavioral health services, and addressing, kind of those social economic barriers for people in the perinatal period. So there are a couple of policies that I think are particularly relevant to rural Arizona, and these policies all come from a recent Health Affairs journal, which is open access. So you can, I have the links here. I can't remember exactly the journal date, but it focused on perinatal mental health. And so lots of really interesting articles there. And I think some of these activities are happening in Arizona. And so I think these are activities that I think could be particularly beneficial to rural Arizona. So one, supporting and facilitating payment for community-based healthcare that can supplement and help coordinate care for people from rural communities, before and after they've given birth. This includes community health workers, community health representatives, doulas, et cetera. Continue funding and sustain funding for perinatal psychiatric access programs, support and fund telehealth and text and telephone-based screening programs. But particularly these last 2 cannot function in rural Arizona unless we make sure that the broadband access is equitable across rural Arizona. And there are several initiatives at the state level unfolding to address broadband access. I do want to highlight, although I focus largely on healthcare and clinical care, that we know that that's a smaller portion, right, of what contributes to overall health, although it's really critically important, in these certain life periods, right? And so I want to give a pitch for some of the policies that can address the social and economic factors, right, that we know really can contribute to health. And these are all policies that can be implemented at a state and local level. They do not have to be implemented federally. And they include universal basic income policies, paid parental leave, increased investment in the childcare system, and improved access and uptake of social programs like WIC and SNAP. And again, these recommendations largely come out of that that series of Health Affairs article. And I pulled them out because I think they're particularly applicable to rural Arizona. One final pitch to wrap up. We have health workforce data resources. The goal of having these resources is to share them with community members and organizations and public health and healthcare folks across the state. I have a link here. You can take a picture of this QR code. I also have the link, the hyperlink on the slide. This is to our core workforce profile report. You can check that out. We have data available. I'm happy to chat about what data you might need or be interested in. You can email me directly or fill out a form on our website. And then lastly, I just want to highlight the folks that all contribute to this project. So that's my presentation for today.